Good morning, everyone. My name is Dr. Iris Gibbs. I am a professor of radiation oncology here at Stanford Medicine, and I am delighted to introduce today's Frontiers in Oncology speaker, Dr. Karen Winkfield. I've known Dr. Winkfield for nearly 15 years and have been inspired by her leadership and commitment to addressing health inequities since our first encounter. Dr. Winkfield earned an MD PhD at Duke University and then went on to complete radiation oncology training at the Harvard Radiation Oncology program. Upon completion of training, Dr. Winkfield joined the faculty of Harvard, first as an instructor and then rose to assistant professor, where she developed a really well-respected clinical program in lymphoid and hematologic malignancies before moving on to Wake Forest as the director of the Office of Cancer Health Equity. Using multiple forms of media to advocate, Dr. Winkfield is the 2018 WebMD Health Hero Award recipient for her cancer advocacy. She is an implementation scientist focused on improving health outcomes for underserved populations through community-engaged research and community-based initiatives designed to improve access to health care, including clinical trials. She has held leadership roles in the premier societies of oncology, including ASCO, where she led the Health Disparities Committee and the Workforce Diversity Task Force, and ASTRO as the inaugural chair of the Committee on Health Equity, Diversity, and Inclusion, which we call CHEDI, which most recently was approved by the ASTRO board to become a formal council with her in one of the founding board roles. Her leadership roles have focused on developing bi-directional communication between researchers and the community to ensure equitable access to care regardless of race and ethnicity, geographic location, and socioeconomic status. She also espouses that workforce diversity is a means to improve health equity. She recently was appointed the executive director of the MeharryVanderbilt Alliance and the Ingram Professor of Cancer Research and Professor of Radiation Oncology at Vanderbilt. Please feel free to use the Q&A feature to pose your questions at the end. But now, let's please welcome Dr. Karen Winkfield, who will speak to us on the topic of bridging the health cancer mission with community engagement. Dr. Winkfield.
Hello and good morning there. It is good morning for you. I am so excited to be here, and thank you, Iris, for such a wonderful welcome. It's amazing. We have known each other for more than 15 years. It doesn't seem like it's been that long, although we also seem like longtime friends. So I'm so encouraged and grateful to be here today. I just want to make sure that everyone can see my slides okay, and that they're actually showing up as in viewer mode.
Yes.
Perfect. Thank you so much for acknowledging. I've certainly gone through entire talks before. People are like, oh, you had a presentation notice. It would have been nice to know that up front. So welcome, everyone, and thank you so much for joining. Today I am going to talk a little bit about some of the things that Dr. Gibbs has outlined that I've been very passionate about for many, many years. And I think what's interesting is my last role as the associate director of the Wake Forest Comprehensive Cancer Center has really opened my eyes to some of the challenges that may exist for other comprehensive cancer centers in terms of understanding how to truly bridge mission, cancer center mission, with this really important goal of community engagement. And community engagement is different from community outreach. We'll talk a little bit about that. I'm certainly seeing that in some of my work now with the NIH COVID SEAL teams. It's really fascinating to see how oftentimes we scramble, after the fact, instead of really thinking proactively about how do we engage communities around some of the things that are important to us. So I think what we'll do is we'll jump right in. Let me go ahead and advance. These are my disclosures. In addition to the work that I've done with cancer centers, I do a lot of work with pharmaceutical companies around trying to understand how to improve, the engagement of underserved populations in clinical trials. It's important. I know today we may have some community partners that are on, so thank you for being here as well. But we need your voice. It's important. And so I do want to start with some basics in terms of helping us to understand, the definitions that we're going to use today. There are 71 NCI designated, National Cancer Institute designated cancer centers around the nation. And this is just a map showing where they exist. Some of them are basic science only. Those are the ones that are shown in orange. MIT certainly has one of those. But really the beauty of this whole system is understanding that the NCI designation provides funding to support institutions that have really shown excellence in research, whether it be population health research, whether it be basic science research, but also making sure that there's excellence in clinical care. This is how we've moved the needle. This is how we change the dynamics around cancer care. But there's also this special designation of comprehensive cancer center. And it's in addition to having resources available, there is an elevation in terms of the quality of the research and also the ability to translate across different types of research. So just again, to set the stage, to make sure that we're all on the same page, understanding the different types of research that really the NCI values and expects comprehensive cancer centers to engage in, there are four broad categories. There's the basic science research, meaning what's happening at the bench, the clinical research, meaning clinical trials, which again move the needle, change how we actually treat patients, the standard of care, population-based research, which really should inform all of those things. And we'll talk a little bit about that, in the context of this concept of community engagement. But then again, the translational research, which moves basic finding, the things that are happening in the lab. What are the findings that are there? And how can we actually translate those to make it good in the population realm and vice versa? All right, so this is where the bidirectionality comes in. And thank you so much, Dr. Gibbs, for mentioning. That's like one of my all-time favorite words, because it's so important when we actually think about the work that we're doing from a cancer center perspective. And look, community outreach and engagement, or COE, which you'll see that on some of my slides, that abbreviation, community outreach and engagement, is not new. However, about 5 years ago, the National Cancer Institute said, okay, for anyone who's getting this funding, this special designation of being a comprehensive cancer center, it is important. It is vital. It is crucial to make sure those institutions are doing community outreach and engagement. But you can imagine, despite the fact that it's been, an important value since 1971, since inception of the NCI designation program, not every center really was doing it. Right? They spoke to it. There may have been a paragraph or two that mentioned the work that they were doing around community engagement, but now it is a full-on section. Anyone who has written a comprehensive or a cancer center support grant knows how long these documents, thousands of pages long, and it's a requirement for them to talk about the programs, the research programs, again, those 4 domains that I just outlined in terms of research, but also what are some of the cores that are available, meaning what are some of the key resources that are available to all of the faculty and potentially community members that are part of the Comprehensive Cancer Center. So today I want to talk a little bit about some of the lessons I learned in really thinking more broadly about how do you actually engage communities around these many domains that the NCI has set up. I tell you, there's been a transition. Those of us who are in leadership, as an associate director and a program director, you have these annual meetings at the NCI, and there certainly has been a shift. But one of the things that was really, really very visible was the fact that the National Cancer Institute, the NCI, really values COE. And in fact, one of the leaders, program leaders, said that, second to the cancer center director, the associate director for COE, is really very vital to the programming, to the success of an NCI designation of being a comprehensive cancer center. It used to be that, only population health really had to think about what it meant to do community outreach and engagement, but now it's across all domains, including basic science. And I think that's where a lot of centers struggle the most, is really thinking about basic science, but also just identifying the community needs. Oftentimes you'll hear people do a community assessment, and all that means is they're looking at BRFSS data, or whatever large database that they can pull data from and say, okay, this is the incidence of cancer, and this is, the mortality from cancer, and these are the areas where there may be some disparities based on race or ethnicity or other demographic information, but they frankly are not sure how to really do a true community needs assessment, and that's important. And so, we'll talk a little bit about catchment area. Again, there may be some visitors that are on the line, or community partners, and that's really just the service area. That's the area where, a comprehensive cancer center has to say, who are the people that we're really trying to reach and serve. Some comprehensive cancer centers will select the entire state. We did not do that at Wake Forest. I'll share what that looked like. And same thing for Vanderbilt now. Yes, it's the state of Tennessee, but we also have adjacent states that we actually provide a lot of services for. So that catchment area and defining that is a really important component of how you actually go about doing the programming, and also how you define what some of the goals and perspectives are. So the catchment area is really important because it helps to catalyze and set the stage for, well, who are the people that we're trying to serve, and therefore who is the community that we actually need to engage with. So we'll talk a little bit about some of those things and some of those lessons learned. But first, again, definitions are important. What is community engagement? And again, it is not public outreach. That's a part of what the COE section is supposed to do, is do outreach related to some of the things that are happening within the cancer center, but also making sure that people understand what new treatments might be available, or the importance of screening, so along the entire cancer continuum. But that's not what community engagement is, and this is where folks get stuck. Public outreach is really focused on a specific project or a specific area. And it's usually, designated for a particular time frame, almost like a task force, right? Where you say, okay, it's time limited. We're going to do this for a year. We're going to understand, the root cause analysis of X problem at our institution. So you get and solicit input from various stakeholders. That's public outreach, the ways to disseminate information. But it actually leaves out some of the bidirectionality that's really important to develop those long-term relationships. And that's what community engagement is. It's really focused on those long-term relationships, building them with the expectation that there's going to be benefits to both sides, right? Not just the institution, but also the community organizations and other providers. It's really about sustainability. How do you develop sustainability? It's not by doing the helicopter research, right? It's not by just popping in and saying, oh, hey, we did this study, or, we have this survey. Do you mind, participating? That doesn't do it. And we see that time and time again, where cancer centers will say, hey, we do outreach, but that's not the same as engagement. And so this is, again, where we have to really have the mindset. Leaders need to have the mindset that community engagement is a long-term prospect. And I always tell folks, community begins at home. How are you engaging your staff at your institution? The individuals who may work in the cafeteria, the people who may be working in environmental services, front desk staff, that's community too. And it's really important to make sure you are taking care of your people on the inside, as well as thinking about how you're taking care of the communities that exist on the outside. So why is it important to think about community outreach and engagement with respect to the work that we do at comprehensive cancer centers? Well, many of you have read or seen at least this report from the AACR, this Cancer Disparities progress report that came out in 2020. It's the first time the AACR has done this, which was actually very well done. It was released in September of 2022, and they actually did a legislative briefing that is still available on YouTube. I believe it was released on the 17th of September. So if anybody wants just a short snippet, a cliff notes, if you will, of what the progress report says, you can certainly go there. And you'll see the different legislators that were involved in the process. Again, really thinking about the fact that, cancer disparities, the differences that we see, a lot of the challenges that community faced are not things that an institution or an individual alone can deal with, but really requires all the stakeholders at the table, including payers, legislators, et cetera. But the beautiful thing about this report, and I must say it was really great to see, is that if you look at the cancer center trends over time, there certainly has been a decrease in terms of the disparities that have been seen between Blacks and whites. And that was the greatest disparity, still is, unfortunately. So if we look, again, over time, we see that while the curves are coming down, that we are actually curing cancers. Cancer is also becoming more of a chronic illness where people may live with cancer for a very long time and then pass away perhaps from something else. The good news is that if we look across all groups, Black men, white men, women, et cetera, that those curves are coming down, which means that we're doing better in terms of our mortality rates overall, but there's still a persistent gap. There's still a difference in terms of the outcomes that we see between different racial and ethnic groups. And the reason why I'm pointing to Blacks is because that really has been the highest, the greatest disparity that has been, but we've been collecting a lot of the data the last several of these disparities. There's the biologic determinants, certainly, that we need to tease out. A lot of folks have really focused primarily on the biologic determinants. This is where our basic scientists come in. And so it's important for our basic scientists to truly understand their value in terms of the mission of the cancer center. Because again, are we thinking about the populations, our catchment area that we're trying to serve? And is the basic science relevant to the things that we're seeing in that catchment area? If you have increased rates of brain cancer in your particular area, do you have good neuroscientists that are there? Or if lung cancer is like your number one diagnosis, do you have clinical scientists who are doing research in lung cancer? Are we treating lung cancer? We have clinical trials open and available. These are the sorts of things that we really have to think about, yes, from a basic science, but also from a translational standpoint. Because again, the clinical trials are some of the things that can help produce some of the biospecimens that are really important to understand what some of those biologic determinants may or may not be. Today, I also want to talk about the social determinants. And for those folks who may have attended ASCO, right? American Society of Clinical Oncology just had their annual meeting. It was very heavy on social determinants. So hopefully, if you haven't had a chance to listen, that you can potentially still, I think you still have access to ASCO at this point. But there are a lot of great talks that actually outline social determinants, how they impact oncology care, how they actually need to be thought about in terms of ways to overcome. So there were solution-oriented discussions. It wasn't just an outline. That bothers me a lot. We've been describing these problems for such a long time. It's really important to think about implementation science and how we can actually integrate some of the things that we've known for decades work. We've known for decades. There are tools, there are methods, there are strategies that have been outlined for decades in terms of ending health disparities, but they really just haven't been implemented, whether it be individuals don't have the will, institutions don't have the will, there may be a financial concern. But I must say that health disparities, cancer disparities are costing this nation trillions of dollars, trillions with T. And that was outlined in the AACR disparities report. So again, I encourage you to take a look at that. So the social determinants of health we'll certainly go into today, looking at socioeconomic status, which we know is the number one driver of health outcomes in the nation. That's income, occupation, education. Those three things are so vital. And again, those are things that are outside of the scope of what we have the ability to control in the cancer center. So how in the world are we supposed to show that the work we're doing has impact in our catchment area? As I mentioned, these issues are not new. This report, Unequal Burden, that was published in 1999, was actually commissioned to look at the NIH's cancer research portfolio and say, what are some things that might need to be done differently? And looking at the disparities that exist, the differences in outcomes that are seen between different racial and ethnic groups. Again, nothing new. And there are lots of things that are outlined that the NIH could do differently in terms of the ways that they engage centers, institutions, researchers around these, even looking at themselves internally. And so one of the things that was really important is people like to talk about race, and we know that race is a social construct. It's not biological. There may be some biologic things that happen because of the social context that people find themselves in, right? Epigenetics. We know that most from smoking, right? That a woman who is a smoker if she becomes pregnant, that her habit of smoking can actually not only impact the next generation, but the generation beyond, right? That's clear. Epigenetic changes in the genome that actually impact generations, right? So again, race is a social construct, but that social construct has biologic implications. Important to kind of keep in mind. But this is why the NIH had even said in this unequal burden report, they actually suggested, hey, let's move away a little bit from race. Let's actually have a conceptual shift that says, hey, let's look at the environment, right? Let's look at those social conditions. Let's look at the other factors that may actually impact one's ability to not only access cancer care, but also what are the risk factors that may actually come into play related to that environment. And so this is why, again, definitions matter. I actually really like this definition from the National Institutes of Health in terms of what are health disparities. We can talk about it. You know, a lot of times when people hear disparities, they're like, oh, it's going to just be about racism. Okay, that's one component. But remember that health disparities are really the differences in not only the incidence and prevalence of disease, mortality, et cetera, right? Burden of disease, but it's other adverse health conditions. So yes, racism is one of those adverse health conditions that exist, but you got to think about the other population groups. This is not just about race, ethnicity. This is about geography. Geography matters. Again, one of the major lessons I learned as a leader in the cancer center, that for my cancer center when I was at Wake Forest, where 59% of the counties that we serve are highly rural, problematic when it comes to access to oncology care. So yes, while I will be basing a lot of my discussion today in terms of the differences that we see in terms of racial and ethnic groups, please understand there are other groups, LGBTQ+, adolescent young adult medicine, what's happening at the age extremes, even our older adults. And I say extremes, as I get older, I tell you, 65 is looking younger and younger, right, as I age. But let me tell you, these are populations above age 65 that we need to make sure have inclusion in terms of the studies we're doing. What is the impact of aging on cancer risk, right? Are there lessons learned from that process that may help us to better understand cancer and how we can combat it? The social determinants of health, really important for us to get our brains wrapped around, even to the extent where we can explain it to lay individuals, but also to scientists. Look, I'm a biochemist, okay? That PhD, biochemistry, right? I really tried to get away from it. That was my undergraduate degree. And so as I went to my PhD, I really wanted to be someone I was like, all right, I need to be doing more stuff in genetics, et cetera, in genomics. I don't know what happened, but I ended right back doing mass spectrometry and biochemistry. But the bottom line is, look, as a basic scientist and having that mindset, I understand you can get so focused on the problem that you're looking at that sometimes it's hard to take a step back and say, what is the bigger picture? And so this is where the bidirectional communication between the different groups, talk to your population health scientists, right? Have conversations that actually help to inform the work that you're doing at the bench, and vice versa. These are things that we can do, but it's really important to understand the concepts of social determinants of health so that we can have those conversations. You know, it seems like, well, money shouldn't matter, right? Well, what does income have to do with anything? Well, it certainly has to do with access to care. It also can impact one's ability to participate in precision oncology, precision medicine, right? Some places do not fund individuals to get simple testing. We know, frankly, for instance, that African-American women with breast cancer are not getting Oncotype DX testing at the same rates. Some of that's because they're not kind of getting asked, but some of it may actually be related to income or insurance. But that can be problematic from a basic science standpoint, right? When you're trying to get a sample and you need that biospecimen. Trust me, I understand. The reason is the demise of some of my studies. I just couldn't get enough samples. Neighborhood and physical environment, really key to understand how the environment impacts and influences genetic makeup. What are those epigenetic changes that happen based on stressors external? But also for us to understand from population health science standpoint and also a clinical research standpoint. When we're doing clinical studies, how does transportation impact individuals? Like what? Seems kind of ridiculous to have to talk about, but let me tell you, in my work, when you ask people, the #1 barrier to cancer care in the country is transportation. Doesn't matter if you're rural or urban. Transportation, #1 issue. So how does that impact what we do at the Cancer Center? How does it impact what we do as a clinician scientist? When we want to engage people in clinical trials, what's our thought process? How do we design the study? Who are we designing the study for? Food insecurities. I can't, it's one of these things that I've said before, but it really dawned on me that I wasn't putting things into practice. We always talk about the importance of understanding the context that our patients find themselves in. And then yet, it's like, oh, okay, never thought to ask whether or not people had food at home. There was a recent study that showed that about 33% of cancer patients have some form of food insecurity. So again, what impact does that have on outcomes? Right. So one of the things that I think is really important is to understand this concept of social context. Again, the social determinants. I love this slide. This is Kaiser Family Foundation. The reason why I love the slide is because it gives examples so that people can truly understand what the social determinants of health are, and not just this big kind of concept that's out there. But I want to say to each cancer center, to Stanford Cancer Institute, that community engagement is one of the social determinants of health. How you engage the community, how you engage your catchment area is one of the social determinants of health. Puts a whole different spin on it, doesn't it? What you do can absolutely move and drive the changes that happen in your communities. But it really does require a concerted effort. We're seeing this with COVID-19. I think I mentioned that I do work with the National Institutes of Health. I actually co-lead their inclusive participation work group for their SEAL teams. That's the Community Engaged Alliance Against COVID Disparities. And again, the difference between outreach and engagement is vast. The vaccine was developed very quickly, although it had been in the works for decades, right? Nothing new about the vaccine. But the fact that the public really had no knowledge of it, there really was this outreach campaign to try to get people to understand that, hey, this is not like something that we just kind of rushed through. There are already folks working on some of the components, right? But the thing that's important that I pulled from COVID-19 is that there are so many similarities between the risk factors, not only for the development of COVID-19 or getting COVID-19, but also the development of the morbidity or mortality related to, right? So the exposure risk and the risk of having poor outcomes from COVID-19, many of those things that we are seeing now, or we have seen over the past year and a half, are things that those of us in the cancer care world have been seeing for a long time, for decades. It's nothing new for us, right? Think about the living conditions, the dense population, right? The racial housing segregation, all of those things, redlining, right? And how that impacts risk for the development of cancer or development of COVID, right? In some ways, COVID-19 has been a little bit of a blessing. The pandemic has really opened the eyes of people to understand what these social determinants are and how they impact not only risk, but also access to screening, access to vaccine, access to treatment. Work circumstances, people who are being labeled as, vital employees, but yet not being paid, workable or living wages. In North Carolina, again, the national hourly rate is still $7.25 in 2021. Imagine how many families are living in poverty, but yet they're essential workers. And so they're forced to come into work and have exposures to COVID or whatever, chemicals, other things, right? That can impact not only their risk for COVID, but also cancer as well. We certainly know that insurance, lack of insurance, underinsurance, all of those things are really things that those of us in the cancer world and in oncology have struggled with for such a long time. How do we actually bridge the divide? How do we really make sure that we as oncologists have the capacity to really think about these issues in a different way? Again, a concerted effort is required. So leading health disparities that we see, obesity, cardiovascular disease, we mentioned COVID and cancer. Again, I'm going to talk a little bit about race and ethnicity because I do think it's important to understand that Blacks in this country have the heaviest burden for all of these, as do Indigenous populations. The challenge is that our Indigenous populations are so low, the numbers are so small. But I think particularly in California, where there are large numbers of tribes, it's something to think about. How are you engaging those communities? And are there things that you need to do differently to engage one racial ethnic group versus another. It's really hard to really wrap our brains around this because, when we think about cancer care, medical care in general, this is a great slide from the CDC that I love, only accounts for about 20-25% of outcomes, right? So if you're like, okay, I want to look at, what the cancer rate is, and I want to look at the outcomes in terms of how, Black, Hispanic, Asian Americans do compared to white, LGBTQ, whatever it is, whatever the comparator is, knowing that only what you do as a medical provider, as a medical institution, only accounts for 20-25% of the outcomes can be a little daunting. But this is where population health is important, right? This is where making sure that our population scientists are understanding our catchment area, understanding the drivers, understanding the conditions that people live in, so that they then can better inform the work that we're doing at the Cancer Center to help strategize around that. And again, this is the importance of community engagement. One of the things that I was really been blessed with, again, I think COVID-19 has allowed those of us who've been at the forefront of doing this type of work for years to say, okay, let's look at COVID-19 and let's strategize, because there can be some lessons learned from how we were actually able to mobilize communities and institutions around thinking about access to care and health equity in a different way. So this is a paper that my colleagues and I published last year that actually kind of try to outline some of those lessons learned. How can we be engaged, more engaged in bringing equitable cancer care to the communities we serve? Again, it's pretty daunting. Think about, okay, I can impact 20-25%, but that's only within the context of care. What are we doing external to that, outside of that? So a couple of things that we outlined: make sure there's more research and advocacy for health equity. Research is a given. We'll talk a little bit more about that, clinical trials certainly. But when I talk about advocacy, that's policy. But that means policy implications for not just thinking about what happens at the national level or the state level. Certainly that's important. The local level is even more important. What's happening at your institution? How accessible is your institution? How welcome do people feel when they walk through your doors? All of those things are important. And are we doing the research in our own institutions to make sure that we're doing that? I understand that Stanford has done some of that work, and I congratulate you. I look forward to hearing about some of that and some of the results, because I think that's an important first step. What are we doing, and how do we feel to community members as they walk through the door? What's the environment we're creating for the faculty, for the staff that are there? Do we have a diverse workforce, and not just physician workforce? That's important. With only 3% the oncology workforce being Black, problematic, but we know that it's not going to change overnight. 4% of the oncology workforce being Hispanic, not great, but again, not going to change overnight. So what does it look like? What does our center look like? What are the other aspects of the workforce that we can actually impact more immediately? And have we done our best to develop excellence? Have we looked at our trainees, medical students, residents, fellows? And what are we doing to ensure that there's the inclusion for those populations? And are they patient-facing so that we can really help them to understand, or community-facing, what it means to do community work? These are all important things. So one of the things that I think is really important, I learned this again, and really if you look at the description of what the NCI is looking for in terms of community outreach and engagement, it really does promote diversity, equity, and inclusion. That's an important component of what the COE section does, not just in patient and clinical care, not just in terms of approval to clinical trials, but also recruitment and retention. That means faculty, yes. But again, I think that we need to be thinking about the entire care team. That means from the person who is in the registration office, picking up the phone, talking to our potential patients, talking to our community members. Are they diverse? Or is it a diverse and inclusive workforce? All of these areas are important. What's the climate like internally? These are hard questions. These are things that really you have to grapple with. And look, I'm saying this from someone who, when I first went to one of my institutions, there were 3 Black medical oncologists, 1 Black radiation oncologist. And I was like, oh my goodness, this is like the most diversity ever. I was the first Black radiation oncologist hired when I was at Mass General. And to this date, the only one hired on faculty, right? So for me to go into a setting where, oh my goodness, there are other colleagues that look like me, it shouldn't matter, but it does, frankly. We all know that. We feel more comfortable being around people who understand our lived experience. And yet by the time I got there, within 2 years, 3 of those individuals left because of climate, because of culture. And it's important for the institution to really do root cause analysis. Why did they leave? What were some of the issues that they were facing? It didn't happen. And that's one of the reasons why I left, right? Because it's important to those of us who are from communities that have been disenfranchised to know that our institution has our back, that they're really invested, that the diversity is not just the checkbox, that we're not just somebody walking through the door that they can say, hey, look, we have a Black person or a Hispanic person or one single LGBTQ plus member on our team. But that we're valued, that our thoughts matter, that our representation of the communities that we serve matters to the institution. Let me tell you a story a little bit about Wake Forest. Again, I already mentioned there were 58 counties in our catchment area. And again, catchment area, for those who may be new to this term, is just what is the service area? Where are the area? Where are the patients coming in to the cancer center? Where are they coming from? And we actually had 58 counties that spanned 3 states. And so it was very interesting. North Carolina, so Wake Forest is in Winston-Salem, North Carolina. North Carolina has 3 comprehensive cancer centers, so Duke and UNC, who are a little bit further east, and both of those actually use the entire state as their catchment area. It was really important for Wake Forest because of where we're located. Some of you may see this kind of dark band here. That's actually Appalachia. So Appalachia is right in the service area. So when I talk about really getting a steep learning curve, understand not only rural communities, but also rural Appalachian communities, which, as you know, have some of the worst outcomes in the entire country when it comes to health disparities. And so this very highly rural, mostly white community was in our service area, and we need to figure out what are the best things that we can do and how can we serve them. So this is the catchment area for Wake Forest. And one of the things that was important for me as the associate director is to understand what the entire cancer continuum, right? What are the barriers? What are the things that we potentially might be able to impact and influence as a cancer center along that entire cancer continuum, which includes prevention, right? So Winston-Salem, the city named after 2 cigarette companies, okay? Tobacco. 71% of our counties had smoking rates that were elevated above the national average, no surprise there. So tobacco was an important thing to make sure that our cancer center was really focused on tobacco prevention, but also, lung cancer screening, et cetera, making sure that we were doing what we could as a cancer center to address some of those things. Detection, right? So lung cancer screening, now a thing, right? So it was really important to make sure that we integrated that into our practice as soon as we could, to understand what are the ways that we can not only improve public outreach, but really to engage them in that conversation around lung cancer screening, knowing that there may be some downstream consequences that we all need to be prepared for if in fact the nodule is found, right? Some of you have seen the papers that have talked about the rates of finding nodules that may be benign and all the procedures that happen. It's part and parcel of screening, right? Especially for those high-risk individuals. But the entire cancer continuum, so including not only the screening and diagnosis, but treatment. And I actually put clinical trials in treatment. One of the things that I think is really important for us as oncologists to do is to not make clinical trials something other. It needs to be part of standard care. And that's really important to make sure that we are engaging communities around clinical trials, really, engaging them at different points in time, which are really important. But all of these are important issues. And this was the team that I actually led at Wake Forest. It does require a team to do this work. So what does your community outreach engagement team look like? How are you engaging that? Dr. Gibbs mentioned the Office of Cancer Health Equity, and this is the team. And what we did was I made a clear, conscious decision to think about programmatic support versus population health. So we built a population health navigation program, which these are individuals, quote unquote, lay individuals. And I say lay in air quotes just because like Emily was she's a social worker, right? Alexis had a master's in criminal justice, and Maria was a lawyer. So I say lay in air quotes just because they're not a clinician, so they weren't a nurse. So clinical nurse navigation has been one of those things that people say, I'm not sure how much value that brings. I think it brings tremendous value to patients, particularly in the cancer journey, but I think that the population health navigation is really vital. And I talk about that in some papers and things, and I'll provide a few references for you. But the reason why is because these are individuals who are from and of the communities that they are intended to serve, who have received special education around navigation, who really can meet people where they are and help them to understand not only the importance of coming for cancer care, but also thinking about research. All right, so that's an important component. And all of this work is actually overseen by Community Advisory Board, a real and integrated Community Advisory Board. And we can certainly talk about that if any folks have questions about how to do that. So I do think that community assessments need to just go beyond just looking at the demographics and the numbers. Again, we do have to define our catchment area, which is important. What are the demographics? Who are the people we're serving? What's the racial ethnic component? What are the finances? You know, what the geography? Understanding behavioral risk pattern, all of that stuff is important, but really what you want is feedback. You want to hear from the community in terms of what their priorities are, what are their health priorities, and what are some of the strategies that might work. Again, different for each population. You cannot approach American Indian tribes in the same way that you're going to approach the Black community. They're different populations, so there have to be different strategies. And the only way to really know what those strategies are is to really have deep conversations with the community members, identifying some of the needs, and then again, responding to the community. One of the things that our community had said at our cancer center, it costs too much to park. I'm coming in for radiation therapy every day and I've got to pay X amount of dollars, right? So, okay, we said, all right, you're gonna have free parking when you come in for radiation. Made a huge difference. Seems like kind of ridiculous, but it did. But other cancer center members were saying the same thing. Hey, I want to come, you know, I have to pay X amount of dollars. So we were trying to figure out at Wake Forest how we can actually make it so that the cancer patients, you know, didn't have to pay so much out of pocket for things like parking, again, transportation being the number one barrier. But hearing them and saying, okay, what are the things that we can do to make a difference is really vital to this community engagement. I'm going to briefly, let me look, I don't have much time. So, so let me just go briefly. Population health science is actually one that most people understand how community engagement is related. So one of the things that we did, as I mentioned at Wake Forest, is thinking about lung cancers being our primary diagnosis. I walked through the door, but also being in very, very high risk counties, is I actually said, well, where are the lung cancer screening facilities? Nobody had thought to ask that. This is where population health can help to inform, right? So we actually found out that there were huge gaps, as you can see, in terms of where our catchment area is that did not have lung cancer screening available. So it's really hard to do outreach when there's a problem with respect to access. So that's one thing to keep in mind. But also it's really important to kind of outline, because when you have implementation scientists that you're working with, they need to know where some of these facilities might be. So always think about doing asset mapping, you know, as you're starting to design and think about, you know, the types of programming that you want to put in place. Clinical research, again, I mentioned who are we designing clinical trials for. And when we look at the access to underserved minority populations, we see that they're just so underrepresented, as you know, in cancer clinical trials and just clinical trials in general across the board. The FDA suggests that only 4% of participants in clinical trials that have really helped to bring to the fore, you know, many of the new medications that we're using. Only about 4% of those are represented, underrepresented minorities, or, you know, racial and ethnic minorities. So we've got a lot of work to do. And this is a prime example. Look, I'm a heme radiation oncologist, as you heard. So multiple myeloma is like one of my things. I love it. You know, I don't love the fact that my mother-in-law has multiple myeloma, but it's an amazing and fascinating disease, right? So we know that African Americans are overrepresented. Now, 2 to 3% higher risk for African Americans for development of not only MGUS, so monoclonal gammopathy of undetermined significance, which is a precursor, or multiple myeloma, right? 20% of the myeloma patients, 1 in 5 is African American. And yet when we look at the clinical trials that have been done, that have been wonderful in terms of coming up with great strategies around treatment, only 5% of participants are Black. Who did we design the trial for? How can we be sure that not only are the drugs going to be as effective, but have the same side effect profiles in different populations? Really important to think about that as we strategize in terms of how we're thinking about clinical trial design. And, you know, what's fascinating is I hear people talk about, oh, well, African Americans, they don't want to participate in clinical trials, or they're more challenging. And let me tell you, I've done some work. This is a paper. Feel free to take a look at this. Well, I actually engaged the Black community and did some qualitative mixed methods, work, saying, hey, what do you guys think about, clinical trials? And, people are willing. We just have to think about our eligibility, right? What are your eligibility requirements? And are they too stringent? Are they unfortunately excluding people even before they walk through the door? I had a sponsor come to me and say, hey, we'd like you to be part of this trial. And they showed me kind of their mock-up, and they had, okay, patient excluded or inclusion criteria, BMI less than 25. They're excluding half of America, right? Especially the Black population, Hispanic populations. The Black population, I think we're at 70% of the Black population being obese or overweight. Think about those inclusion criteria as you're writing your clinical trials. And then we know that geography matters. Like, again, I learned that incredibly in California. You guys have so much space. So I know that geography matters in terms of being able to get people enrolled in clinical trials, but it's something to think about. But so does patient income level. Again, what do you do about that? What do you do about poverty? This is a paper that my colleagues and I, when I was at Harvard, we actually designed a cancer care equity program. We looked at the ability of really driving and changing how people perceive clinical trials based on helping to support them financially during their cancer journey. This paper was published in Oncology a couple of years ago, so I'll allow you guys to read that on your own. But really important to think about the financial implications, not only of cancer care, because remember, cancer care is the #1 cause of medical bankruptcy in the United States, but also how a clinical trial is designed and whether or not that actually can exacerbate some of those issues. ASCO's certainly been thinking about this as well. This is a paper that my colleagues and I published looking at some policy implications related to barriers to participation in clinical trials. Very pleased that HR 913 was finally passed, which is the Treatment Act, which allows or states that patients on Medicaid are now allowed to enroll in clinical trials. The implementation is going to roll out in 2022. But again, this is a great paper to think about what some policy level changes, both at the institutional level and also national, might be needed to make some difference. And this is, again, COE related, policy as part of community outreach and engagement. I did want to share kind of this one success story, and then I'm going to wrap it up because I'd love to get to some Q&A around population health navigation. I mentioned my colleagues at Wake Forest, and one of the things that was really important to me is to say, how do we show and measure progress? What we did was we actually looked at the patients that we were navigating this population health navigation and showed that just by providing psychosocial support, just by providing racially and culturally concordant care, somebody who says, hey, I see who you are, we were able to not only improve their journey through their cancer care, but also to improve clinical trial enrollment by 50% in each of the populations. Incredible. Hispanic, rural, and African American patients, 50% increase in terms of inclusion. One of the important things that I really point to, and I'm very grateful that we have the opportunity to do this. This is another reference that I'll point you to. This is a paper that my colleagues and I published in January that is the development of an actionable framework. It took some of those examples, just like the population health navigation program, and we took experts from around the country and actually did a roundtable with them back in 2018. It took a long time to put this paper together, but I think it actually outlines a great framework that institutions who are interested in doing real kind of health equity and ensuring health equity is important for their standard of care. This is a great framework, but it was really important for me to understand, for folks to understand who the stakeholders are, making sure all the stakeholders are represented, who are the medically underserved populations, again, not just race, ethnicity, but then also really important community engagement. Community engagement is the #1 component of that. So this is a great paper published in the Journal of Oncology Practice that hopefully folks will take a look at. And I think it's really important to think about how you're seen. What is your mission, your institution? How are you perceived in the community? That's an important thing. I did want to mention the community engagement studios at Vanderbilt. They have a toolkit that's available online, so feel free to look that up. It's a great way to kind of think about engaging community at a different level, and it can be used across the board when it comes to basic science, translation, or clinical research. We really need to start thinking about engaging the community, not at the end, not after we've already done the work, but really at the beginning. And frankly, we should be including them in the process of how we think about this. And some people are like, oh, well, it's lay people, they're not going to know. Well, this is where the Advocates for Research and Medicine program comes in. A program that we actually established at Wake Forest that's now kind of being propagated through the NCORP research bases, so the National Cancer Institute's NCI's Community Oncology Research Program, Alliance, ECOG, ACWIN, these are cooperative groups, but the Wake Forest research base also has research, but mostly on implementation science and also looking at patient-reported outcomes and survivorship. We actually have a program now where we are training individuals who are either patients themselves, family members, somebody who's been impacted by cancer, to really help us to understand what it is that they want and how to engage them in the research process. We train them up, we help them understand what the advocate's role is, and help them understand research. And this is a great way to train individuals to actually participate in basic science and the design of basic science as well, as looking at clinical and translational research. So you may have gotten the supplements at Stanford, I can't remember, but there are lots of supplements that come through the CCSG that provide some infrastructure money that can help support, programming. And those are wonderful. So please take advantage of those. I mean, I was able to get $3 million in grants in 2020 to really help support the work around COE for Wake Forest before I left. And this was one of the programs, bidirectional research involving diverse groups through engagement. And this is where we actually really designed a program that really helped to improve the bidirectional communication between basic scientists and community members. And great opportunities to get some funding to help support not only faculty's champions in our basic science departments who are going to do this work. So hopefully keep an eye out for those sorts of stuff. Okay, so I'm going to stop there. I do think that it's important to think about the mission of the Cancer Center and how that actually is being looked at. We don't just do this for money, but I do think that from the Stanford Cancer Institute, one of the things that I felt was a little bit buried was your focus on community. I know you guys do the work. I know you do. I've partnered with you guys for years. So really important to think about what the community sees externally, okay, as you go through this work. All right, so I'm going to leave it there, folks. I would love to see if we have, because I want to leave some time for Q&A. I apologize for being a little bit long-winded, but hopefully you found the information valuable. Dr. Gibbs had mentioned I do a lot of different mixed methods and mixed media. I do have a podcast called 3 Black Dots. My colleagues, 2 medical oncologists. We really are trying to provide access to information at people's level. And so hopefully you guys will check it out and pass it on to some of your patients. Thanks so much for your time and attention to me. Appreciate it.
Thank you so much, Dr. Winkfield. Awesome. I do see that there are a couple of questions, and I think we have a little bit of time. And the first question comes from one of your colleagues, one of your former colleagues at Boston that we have here, Dr. Lydia Shapira, saying thank you, Dr. Winkfield, for a spectacular talk. And as you think about creating a more diverse and inclusive oncology workforce, how do you imagine creating a flatter, less hierarchical, and more welcoming organizational structure where people feel safe?
Yes.
I worry that we are placing too much emphasis on leadership and not paying enough attention to the value of every member of the team. What are your thoughts?
Yeah, so first of all, Lydia is not just my colleague, she's one of my mentors. So let's get that one straightened. She has really, as you all know, she's phenomenal, has this amazing grasp at communications and really understands the value of that. So she took me under her wing when I was at Mass General. So thank you, Lydia. Thank you so much for your question. I agree with you that there oftentimes is too much emphasis placed on leadership. So that's why I talked about the workforce, not just physician workforce. I think that's important, but also every member of the care team. And that, again, does include people who are literally picking up the phones. What does your institution look like when you walk through the door? Who's sitting at the front desk, right? And what types of questions are they asking? So one of the things that I'm doing, so you all heard, I'm brand new to the MBA, started in November. And this is a huge issue, even for people who've been there, because our institutions tend to be very hierarchical. And so the old guard that was working in my current at the MBA was very much into the hierarchy and what does it mean and what is the org structure and who's a leader. I'm like, no. Let's talk about intersectionality. So we think about that concept of intersectionality. What I've done at every team that I've developed is to actually create Venn diagrams, okay? Yes, you may have a content area that you're an expert in, right? So you might be the lead, if you will, for that particular project or program, but who's supporting you in that? And that actually does create more of a team-based approach to the way that we lead. That's vital and that's critical. Now, look, my colleague, Dr. Famika Chino, who's a radiation oncologist at Sloan, recently just published a paper, I think came out 2 weeks ago, that talked about the lack of diversity in leadership. So that's important too, though. We've got to have leaders who come from diverse backgrounds, because otherwise they're not going to come up with the innovative strategies, right? If you keep doing the same thing over and over again and expecting different results, we all know what the answer is, right? So we've got to shake that up so that we can bring in folks who do think about building teams and having team-based approach to some of these works. Thanks, Lydia.
And then another question from Dr. Patel, Dr. Manali Patel. A wonderful talk. Sadly, community engagement is seen as an obligation and a burden at some institutions, and this falls on a few individuals. Can you talk about the strategies on how to include the community engagement into the rubric of what we all do as members of the institution and faculty?
Yes, and hello, Manali, another one of my colleagues. We work together at ASCO Health Equity Committee. So good to have you. Thank you for showing up today and for your question. Really important. Again, everywhere that I've gone, I think it's really important to say, how do we bring engagement, not just to the Office of Cancer Health Equity, for instance? It has to be interpolated into the fabric, as you've mentioned, of the entire institution. So one of the things I did was I created opportunities for engagement that were easy, right? Got a health fair. All right, let me go ahead and see if I can get our students, our fellows, other trainees, our faculty out at that health fair. The other thing that I did was actually designed a faculty speakers bureau. You know, it seems ridiculous, but it's simple. Communities are really interested in hearing about the work that's happening at the Cancer Center. So get your basic scientists, get your translational researchers, get your clinicians out there. But the only way the way to do that the best is to create a speakers bureau. Now, sometimes you have to encourage basic scientists to think about putting things in lay language, right? So it's really important to make sure that if you're going to bring basic scientists, really have an opportunity to help educate them and inform them. This is where, when I talked about that bridge program, actually, believe it or not, did a training with the basic science faculty, right? Where they actually sat down in front of community members and presented their research and got feedback, direct feedback from community members. Because if the community members don't understand what they're saying, then what's the point of having them go out and do the engagement work? So the engagement can be at different levels. I always encourage people to understand advocacy and the power of that, not only institutionally, but also on the local and the national level. Advocacy is really important, and that's an important component of COE. So thank you, Manal.
Great. And then there's another question, and I'm delighted this one happens. He's hitting the ground running. He's one of our newest residents in radiation oncology here, Kakoa Tapara, who says, you mentioned basic science as important to cancer research in the context of race as a social construct. And I struggle as a bench researcher on how to focus on specific populations, as I feel it often de-emphasizes social determinants of health. Any recommendations on the approach that basic science cancer research to improve health disparities while also maybe engaging with communities? And maybe this is an extension of what you were just speaking of.
Yeah, so Kakoa, good to see you. I'm telling you, all these folks I have connections with, right? So Astro Fellow, great to have you. Thank you so much for your question. It is, I think, again, the integration of basic science and COE has been the toughest for lots of folks. But remember what the social determinants of health are. Remember that little kind of square, that box I showed you from the Kaiser Family Foundation? Environment, right? What are the environment exposures that people are finding themselves in? You know, have you done overlays in your catchment area? Like if you're seeing pockets of cancers in areas, have you done any overlays? We actually did that with radon because we were having these weird pockets. Again, we had smoking, heavy smoking rates, but there were some really highly elevated, rates of lung cancer, and found out that there is radon, sitting right there. And, it's really important to kind of think about those environmental exposures. But I agree that sometimes it can be harder to think about how to integrate basic science. I still think race is important because, again, it is a surrogate for racism. It's a surrogate for other stressors that we are seeing. So I would not discount that. So again, my work when I was at Duke was really trying to understand the differences that we were seeing in between Black and white women and the biologic basis for those differences. Those are just good work coming out of that, right? So don't discount that. I'm not saying to discount the fact that we can still use race as a surrogate when we're thinking about our basic science questions, but also think about the other components of social determinants of health, particularly the environmental exposures. And this is where talking with the population health scientists, this is where a comprehensive cancer center means just that. How are you translating the work across all of the domains, right? And that means there has to be clear ways of people to engage together. So I would encourage you, people, if you haven't done it, talk to some of your population health scientists, talk with your associate director for community engagement, and really get some ideas in terms of what are the things that you can do right at your institution that might actually help to support the work that's being done in the catchment area.
Well, it seems that we've come to the end of the hour. I want to thank you so much for giving this wonderful talk, and we are delighted that you've done this. So thanks again, and hope to see you again soon in person.
Thank you so much for the invitation. Thank you all for taking time out of your day. Really appreciate it.